Hello, good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS Webinar. The speaker for the first session of today is our honorable guest from Istanbul, Turkey, Professor Abuzer Gungor. Professor Abuzer is the Professor of Neurosurgery at the University Hospital. He's also in charge of the famous Neurological Laboratory. Was a past chairman of the Young Neurosurgeons Committee, WFNS Young Neurosurgeons Forum Committee, and he's the specialist in fiber dissection technique and complex cell-based approaches. He's a local scholar who published in several landmark articles in leading journals and also has more 1,500 citations. We're extremely thankful to him for accepting our invitation to be the speaker of our webinars. And today he will be talking about supracerebellar infra-tentorial approaches. The speaker for the second session of today is our very honorable guest from China, Dr. Jin Yi. Dr. Yi is the consultant neurosurgeon in the neurosurgical department of the Huashan Hospital in Shanghai, China. His clinical interests are mainly focused on the diagnosis, neurosurgical operations, and medical treatments in the traumatic brain injury patients. He is also a noted author who has published in several leading journals. We are extremely honored to have him today with us to be the speaker of our webinar, and he will be talking about the rescue for critical state of SIH, spontaneous intracranial hypotension. The chair of the first session of today is our honorable guest from India, Professor Abuzer Gungor. Professor Gungor is a consultant neurosurgeon at the Department of Neurosurgery, University Hospital and Research Center, and Mumbai Hospital and Research Center, and Tata Memorial Hospitals. He's a professor of neurosurgery at the R.N. Cooper Hospital and Medical College in Mumbai. Professor Gungor is a well-renowned authority for cranial cervical junction pathologies. He is an orator par excellence in neurosurgery, who is an invited faculty for workshops and conferences worldwide. He is an inventor of several neurosurgical techniques for complex pathologies, which are currently employed in neurosurgery worldwide. We are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today is our honorable faculty from Italy, Professor Giorgio Palangi. Professor Palangi is a consultant neurosurgeon in IRCCS Institute of Neurological Sciences of Bologna, Bellaria Hospital via Artura 3, Bologna, Italy. He was previously a visiting in the Mayo Clinic and Rochester, USA, and also consultant neurosurgeon at the Imola City Hospital in Imola, in Italy. His clinical expertise is focused upon management of hydrocephalus and endoscopy. He is an invited faculty to various workshops and conferences around the world. We are extremely thankful to him for accepting our invitation to chair the section of Professor Jin Yi. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and the chairs and the audiences to this online platform of ACNS. A very warm welcome to our colleagues in China. We are extremely thankful to Professor Shibin for broadcasting the webinar on the WeChat channel. Liu Bunxing from Malaysia is my co-host today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Abuzer Gungor. Professor Gungor, please.
Yes, thank you. And I'm actually eagerly looking forward to what Dr. Abuzer has to say about supracerebellar, infra-tentorial, and transtentorial approaches. This subject has been of my great interest for a very long time, and I am eager to know the recent thoughts on this subject from Abuzer. I know he is working with my dear friend, Dr. Abuzer Toure, and I'm sure I will enjoy whatever Dr. Abuzer has to say. Dr. Abuzer, please start your lecture.
Thank you, Professor. Thanks for your invitation. It is an honor to be here. I will talk about the supracerebellar approach, also infra-tentorial and the transtentorial approach. I have nothing to declare, but I have a big team behind me, also my mentors and my fellows. I am lucky because I learned microsurgical anatomy from Professor Rotten and the microsurgical techniques from the Professor Toure and Yashagil. There is a photo from operating room, and the Professor Ture and Yashagil were discussing about the case. I think it's about 5 years ago. Professor Yashagil always joined the vascular cases from beginning to the end. And this is the last photo of Yashagil with us in the laboratory about maybe 3 or 4 months before his death. And we also we published several papers about the white matter tracks and the supracerebellar approach you can find in the literature. I will use all information from our articles. When we talk about the supracerebellar approach, there's some terms like the median, paramedian, lateral, and extreme lateral approach, and also infra-tentorial or transtentorial ones. When you go laterally, you will have a direct view of the midline structures because of the structure of the cerebellum. It's like a tent. When you approach from the laterally, you can have a direct access to the midline structures. We always use a perimedian or paramedian approach. Professor Ture used perimedian approach to reach the midline structures and paramedian approach to reach the mesial temporal structures, but I always prefer to use the paramedian one. We always use a unilateral approach. Why? I will discuss about that. You can reach structures. This is the tentorium. We are looking from the superiorly. You can reach all these area with cutting the tentorium, and also the superior surface of the cerebellum. You can reach via supracerebellar approach. The supracerebellar approach mostly used for pineal region, but also you can reach this region via the occipital approach, occipital posterior interhemispheric approach, transtentorial approach. But in this approach, you may need a retraction of the occipital lobe. In supracerebellar approach, you don't need to retract any structures if you use gravity. And in the midline structures, also tentorial structures, you can use the subtemporal approach, but when you use subtemporal approach, also you need a bit attraction of the temporal lobe, and also if there's a labral vein, in dominant labral vein, it can be an obstacle to you. You can reach all these areas, the superior surface of the cerebellum and midline structures like the brainstem, thalamus, and the middle fossa structures via supracerebellar approach. We are looking from the posteriorly. This is cerebellum, this is thalamus, and which structures we can reach via the supracerebellar approach. It is mostly used for the pineal gland, and also superior and inferior colici, the glial tumors or cavernomas, and also for trochlear nerve schwannomas, you can reach via this approach. Also brainstem lesions, and with suprapineal approach, you can reach the third ventricle, also medial part of the thalamus, and also pulvinar thalami. You can reach with the supracerebellar approach and the branch of the P2 and 3 and mesial temporal lobe structures with cutting the tentorium and the superior surface of the cerebellum. And lastly, the lesions located on the tentorium, like the tentorial meningiomas. You can especially the T2 tentorial meningiomas, you can reach via this approach. There's a 3D models to look again the structures which we can reach via this supracerebellar approach. As you see, when we cut the tentorium, you can reach the structures of the mesial temporal lobe like precampal gyrus, and also you can resect the mesial temporal lobe, and also you can reach the pineal gland, the superior and inferior colici, ambient system and branch of the P2, and the third ventricle with suprapineal approach and the pulvinar. And also some authors can use this approach to reach the atrial tumors to use with the collateral sulcus. As you see, also you can reach all vascular malformation located in the quadrigeminal system with this approach. And with cutting the tentorium, this is cerebellum, we remove the tentorium. With cutting the tentorium, you can reach the mesial temporal lobe and the P2 branch. We are looking from the superiorly in this photo. This is hippocampus. This is P2. If we cut the tentorium, we can reach these areas. When we open the supracerebellar space, we can face the bridging veins. They are most located at the mid part of the tentorium. If you go the midline approach with bilateral approach, you need to sacrifice the midline bridging veins, also well-man bridging veins. Because of this, we mostly use the unilateral approach to preserve these bridging veins. This is the Galen venous system, and also you can see the splenum deep on the view and the pineal gland. And when you go here with the internal cerebral veins, you will reach the third ventricle. As we said, we mostly use the unilateral approach. Also, you can combine with the retrosigmoid approach with for some kind of lesions like the epidermoid tumors or also chordomas or big tumors. You can reach all these areas with supracerebellar approach. When we approach from laterally, as I said before, you can have the direct access to the midline structures. And when we open the tentorium, we will reach the inferior part of the mesial temporal structures and the branch of the P2. Endoscope always will help because it's the deep location, the quadrigeminal system and the other structures. Endoscope always will help more. And which position you can use in supracerebellar approach: prone sitting, semi-sitting, and lateral position. As you know, there's some advantages and the disadvantages of these positions, semi-sitting and sitting in sitting positions. You may have a risk of venous embolism. Because of this, you should have a good anesthesiology team. But in prone position, you couldn't use the gravity, but lower risk of the venous embolism. This is the prone position and the semi-sitting position. It is a bit complex position, but if you could do this position, you can use gravity, and without any retraction, you can reach all these structures. And we recently described a dynamic lateral semi-sitting position for supracerebellar approach because I couldn't have a good anesthesiology team, and I had to
Recording in progress.
embolism risk. During the operation, I can change the angle of the table and continue. If there is any complication, I can continue operation. And also this is the semi-lateral sitting position. Also, you can change the angle of the position. And also, your patients may have some variation of the venous system. You must check before the operation. We mostly use the unilateral approach, and also you can combine with the retrosigmoid. You don't need to open all this lateral area if you want to go the midline structures. And when you go deep, you may encounter with the bridging veins and also middle fossa structures you can reach via the supracerebellar approach. And with Professor Ture, we described a technique to preserve the bridging veins during the supracerebellar approach. You can cut the tentorium and release the vein during the operation, and you can continue the operation. This is the cadaveric view. There is a drainage of the vein, and we cut the tentorium, release the vein, and continue the operation. This is one of my case from medial temporal lobe glioma. You can see the vein. We had to release the vein, and we cut the tentorium. You can track the drainage of the vein with ICG or Doppler ultrasound. But most of the time, you can see via microscope the drainage of the vein. After cutting the tentorium, you can see the released vein. Because of this, you must check all these venous anatomy before the operation. You can use any technologies. It's easy to reach this kind of technologies these days. And also, we will publish all these models to the literature. All these steps you can reach with the incision and the craniotomy. We mostly use burr holes above the transverse sinus. As you see, 1/3 above and 2/3 below to the transverse sinus. Firstly, we release CSF from the cisterna magna with a small dual incision, then open the tentorium. And if you go transtentorial approach, you can cut the tentorium and reach the mesial temporal lobe structures. And after removal of the mesial temporal lobe, you can see where the anterior circulating system. I will show some illustrative cases. One thalamic cavernous malformation. The patient came with the hemoplasy. I performed with a lateral semi-sitting position. We always open burr holes above the sinus, transverse sinus, and then we'll release CSF from cisterna magna. And you can release the vein from the cerebellar surface and the tentorial surface. This is preserved vein, and this is the thalamus. We check with the neural navigation. We reach the lesions and remove and control with the endoscope. This is the postoperative view. And also we can reach brain stem, midbrain lesions. There is a cavernoma. We decided to use the lateral mesencephalic sulcus There's a bridging veins we release from the cerebellar surface and the tentorial surface. Then describe the whole anatomy. This is the fourth nerve. We decide to use these lateral mesencephalic sulcus to reach this area. After describing the sulcus, we could reach the carinoma. And dissect from the surrounding tissue. And remove. This is the postoperative view. And also, as I said before, this approach mostly used for the pineal regions. After opening the dura, if you use sitting position and release CSF, maybe in 1 or 2 minutes, you can reach the pineal region. As I said, if you go laterally, you can have a direct access to the pineal region. We reach the tumor and start to remove. This is the postoperative view. And also, you can reach the branch of the P2. This is the P2 aneurysm. And after opening the tentorium, we reach the proximal to the aneurysms, proximal P2. Then put a temporal clip. Then after the clipping, this is the postoperative view and postoperative angiography. And also you can reach the superior surface of the cerebellum with supracerebellar approach. And also sometimes you need to use the contralateral approach. As you see, there's lesions in here, which were the contralateral approach. And also for tentorial meningiomas, especially in 2T type, you can reach where this approach and remove after dissecting the bridging veins, cutting the tentorium and remove with preserving the whole branch of the P2 and the venous structures. And this is preoperative and postoperative views. You can reach all these models from our articles. And from Neurosurgical Atlas with labels, with 2D and 3D photos and models with labels. And we hope we will publish these high quality 3D models soon. As you see, you can see any arachnoids and the nerves and small branches of any arteries and veins. And also, we can perform some cinematic version of these models. As you see, we go through the fourth ventricles and travel inside it. And you are always welcome to visit our fellows, our laboratory as a fellow. We are working with Professor Ture in Yeditepe University. We are accepting fellows all around the world. I want to thank all my fellows to help for this presentation and mentors. Thanks for listening.
Yes, Dr. Abuzer, that was a wonderful, wonderful presentation. Beautiful anatomy. And you know, these anatomy dissections that you have done are absolute. You know, these are not from any book. These are not from Roten collection. This you have done. I know it. And you have done in your own lab to do such clean dissections and beautiful dissection. it is not easy. You have spent time, you have spent days, you have spent nights, you have spent your family time, you have spent your happiness, and you have spent your lifetime in doing these dissections. And I compliment you for your work and for your dedication to this subject and for your lecture, of course. And as you have mentioned, supracerebellar approach, supracerebellar, infra-tentorial, supracerebellar, transtentorial approaches are useful for many instances. And one has to know this. It is one of the big subject of neurosurgery, like pterional approach. You cannot say, I don't want to do pterional approach. You cannot say, I don't want to open the sylvian fissure. Similarly, today, you cannot say, I don't want to learn supracerebellar approach. You cannot say, I don't want to learn supracerebellar transtentorial approach, because it is absolutely useful and absolutely important for various tumors like epidermoid tumors, which go in the perimesencephalic system. They go above the tentorium, below the tentorium. Supracerebellar approach is the most beautiful approach for these tentorial epidermoid tumors, which go up and down the tentorium. Nowadays, you don't want to do huge craniotomy and expose both supracerebellar, both middle fossa and posterior fossa at the same time. There's no need, because you use transtentorial approach, go above and below the tentorium. That is the best way to avoid temporal brain retraction. It is the best way to approach the tumor early in the operation. Like, for instance, petroclival meningiomas, for instance, we have also discussed this petroclival meningioma. And for several of these cases, petroclival meningiomas, you come lateral, supracerebellar, infratentorial, transtentorial, get the tumor very quickly. You don't have to do much bone work of the middle fossa, petrous apex drilling, carotid artery in the petrous apex, trigeminal nerve in the petrous apex, fourth nerve in the edge of the tentorium. All these nerves you can avoid by cutting supracerebellar. It is a beautiful approach. And I have a feeling your anatomy dissection, Dr. Abuzer, and my favorite Dr. Abuzer, what you have done this dissection. I hope this collection is retained for the, in the archives of ACNS, and all those who in the future generations will see these dissections and see these images. Raja, we should keep these images very properly and very, important. This should be kept as a treasure of ACNS webinars, and these should be used. So congratulations, my dear Abuzer, my best wishes, and also convey my regards to my dear friend Ugur. And of course, we will continuously and always miss Professor Yasser. Thank you very much.
Thank you, Professor. We are trying to follow you and mentors like you.
Thank you very much, Abuzer. Thank you.
Ben, there is a question in this chat box also.
I'm about to ask him, because it's also my question. So I would like to, hello Abuzer, nice to meet you here again. And I have a question, which is the same as the chat box. So how would you choose whether you approach contralateral or ipsilateral for this supracerebellar infra-tentorial?
Sorry, I forgot to say, I checked the dominancy of the transverse sinus. If there's one transverse sinus, I select the non-dominant side to, if also for contralateral approach, because you can reach the lesions located close to the midline from contralaterally. And I'm checking the maybe bridging veins, also dominance of the transverse sinus while selecting the side of my craniotomy approach.
I see. And thank you. And I have a second question. It's about surgical position. I learned about the tips, the tricks of this position is that when you have the lateral flexion, and then you also have the flexion, I think the rationale is to open the tentorium to you with that neck flexion. So is that the tricks behind to open the tentorium to you, which is the rationale of this positioning?
Yeah, Professor Ture using this semi-sitting position, but I use the dynamic lateral semi-sitting position. I always use flexion because without enough flexion of the head, it is very difficult to reach the supratentorial structures and lesions. You may have a bit flexions. Also, it is maybe can prevent the venous embolism. Maybe a bit pressure with the venous structures.
True.
I think flexion is important while the positioning.
True. Thank you so much, and really nice dissection.
Thank you.
We have Liu here. Liu, any questions from you?
Thanks, Raja. Thanks. Hi, Professor Gungor. Thank you, Abuzer. I think what we can learn from your technique is, I think essentially it help us to give us an idea what other approaches that we may think that it is not possible. I think by doing a cadaveric dissection, you'll be able to identify all the structure and all the possible or new corridors. So my question to you is, based on your anatomical dissection, how far do you think that we can explore more for more minimal invasive corridors compared to what we know so far? Thank you, Professor Abuzer.
From the supracerebellar approach, I think the most popular and newly one, the approach to reach the mesial temporal lobe and the amygdala. This is the last point you can reach via the supracerebellar approach, and also middle fossa structures like sometimes with the trigeminal schwannomas you can combine with the retrosigmoid approach, and with the aid of endoscope you can reach the middle fossa and remove any kind of meningiomas or the schwannomas. I think also there is one article about removing the colloid cyst from the supracerebellar approach with suprapineal one, but in colloid cyst you will have a narrow third ventricle, and there is a risk of damaging the medial part of the thalamus and the arteriovenous structures. Because of this, we didn't try this approach to the colloid cyst, but also in the supracerebellar approach, I didn't see, but you can reach via the lateral ventricle from the foramen manual. You can reach and see all these structures from supracerebellar way.
Maybe one more additional question to you, Professor Abuzer. As you mentioned that if you come from supracerebellar approach, the main hindrance for us is the vein. And do you find that by coming from midline or paracentral or probably more lateral, give us more advantage in avoiding injury to the vein?
In our study, we showed that they are mostly located at the mid part of the tentorium. But I think it is a bit depends on your luck. For example, sometimes without seeing any bridging veins, you can reach any structures. Sometimes there can be 2 or 3 bridging veins, big veins, and you must preserve these veins, because without preserving these veins, you may have a cerebellar edema and venous infarction. If you use the bilateral craniotomy and midline approach, also you have to sacrifice these midline bridging veins. Without bridging veins, you couldn't reach with midline approaches. Because of this, we are always use the lateral approach, because you have to chance to preserve these veins. In midline approach, you couldn't preserve these veins.
Thank you, Professor Abuzer. Nice lecture.
Thank you.
Professor, I would have also a question for you. First of all, congratulations. That was really a brilliant lecture. I admire you and your work as well. You touched it briefly, but could you spend a little more words on the use on the endoscope? And we have also a question from the auditorium about the use of the exoscope there. So if you can explain a little bit better when and how you use it.
Yes. We are also, I had the chance to use the exoscope, and also we are always use as exoscope, but I am not an full endoscopic guy. Because of this, it is always a bit difficult to remove lesions with the endoscope. I'm a microscope guy. But endoscope I always use to check the after removal, and also can remove the lesions located laterally with some banded suction materials. But also there's some articles using the pure endoscopic approach, supracerebellar approach. But I prefer to microsurgical approach with the help of endoscope.
Okay, thank you very much. And did it ever happen to you to damage, for example, some veins with the endoscope or not? Do you find it difficult to use it at the end?
To use endoscope, because I always afraid to damage the veins while using the endoscope. Because of this, I always use endoscope with the aid of microscope. I am checking with the microscope to all trajectory, because if you don't check the trajectory, you can damage all these veins. Also in retrosigmoid approach, there's a suprapetrosal vein and other nerves. I am always afraid to damage these structures.
Yes, Dr. Chow Wang.
Yeah. Thank you, Professor. Yeah, I'm a young neurosurgeon, but I don't have this kind of experience. But ask you a question is about the should we consider the angle of the tentorium, because I think sometimes the tentorium is very flat, and sometimes the tentorium is very steady. So what do you call this question? Thank you very much.
Yes. I think it is for midline approach, because when you go laterally, you will how can I say more slope, or you don't have to. Also, we checked all the angles, but I had a lot of case. I never had problem about the tentorial angle, because of when you go laterally, it is like a tent, and it is a more, how can I say, located superiorly at the midline, not the lateral surface. If you go from laterally, you don't have problem with the tentorial angle.
Okay, thank you.
Okay.
So if there's no further comment, shall we proceed to our second lectures, and to invite our chair of the second session, Professor Giorgio?
Thank you very much, and good morning, good afternoon, good evening, everyone, and welcome to this ACNS webinar. I am Giorgio Palandri. I live and work in Bologna, in Italy, and it is a distinct honor for me to chair this session. First, I would like to express my deepest gratitude to the president of the ACNS, Professor Yoko Kato, Professor Zhu Bing, for their kind invitation. And I also wish to extend my sincere thanks to Professor Seng and Professor Krishnakutty for their leadership and making these high-level scientific exchanges possible. And I must say that I am particularly pleased to be here today representing the Hydrocephalus Society. This occasion is of great importance to us, and it serves to strengthen the bond between our society and the ACNS, fostering collaboration that is essential for advancing our shared understanding of CSF disorders. And it is now my great pleasure to introduce our distinguished speaker, Dr. Jin Yi, from the Sir Rangban Shou Hospital at Zhejiang University in China. Dr. Yi is a leading international authority in the field of spontaneous intracranial hypotension. He serves at the Headache and Intracranial Hypotension Center, the first and most prominent facility of its kind in China. And under his guidance and through his clinical research, the center has become a global benchmark, managing an extraordinary volume of cases and refining the most advanced techniques for CSF leak localization and treatment. His expertise is especially vital when dealing with the most complex cases. Today, he will provide us with deep insights into the management of life-threatening complications. His talk is titled The Rescue for Critical State of SIH. Professor Yi, it is a privilege to have you with us, and the floor is yours.
Thank you, George. Thank you, everyone. Thank you, the president of ACNS, and thank you, Shiping, to inviting me here. Is the spontaneous intracranial hypertension critical state rescue. As we know that SIH, spontaneous intracranial hypertension, is a mild disease that will puzzle us all. It's presented as bilateral subdural hematoma, that's thin shaped subdural hematoma, and all as well as the CSF collections in the CT scan. The patient always complain about orthostatic back pain, and after the bilateral drainage, especially the misdiagnosis as chronic subdural hematoma with or without trauma, the patient will, some of the patient, and the rarely complication will happen. And the patient will turn to the unconsciousness and the deep coma with brainstem and the brain edema or swelling. After that, the disease is exacerbated. The obliteration of the crural and the ambient system will be diagnosed as the brain swelling and the high intracranial hypertension. And if this happened, and the patient will suffer the herniations, and this complications will beyond our perceptions of the normal chronic subdural hematoma, just as indicated by the CT scan and the MRI. So the epidemiology of the SIH, spontaneous intracranial hypertensions, the incidence of this disease is about 5 to 10 out of every 100,000 people on average, and most of the patient is woman in regeneration period. But unfortunately, the male patient will suffer the predisposition to critical state, and the critical state will have a little bit higher morbidity and the death rate. So it is first described by the German neurologist in 1938. And all these clinical manifestations will be concluded as the first one is orthostatic complaint. Another one is the spinal nerve or cranial nerve stretching syndrome, such as the tinnitus or diplopia or anything like that. And it will cause the brainstem swelling and edema. So the patient will suffer in coma or deep coma. So the inappropriate treatment will end as the patient's death. So in recent years, so many standard diagnostic criteria have been reviewed. The last year, Dr. Schilling have the new criteria of his opinion. This is included the orthostatic headache and the low intracranial pain and intracranial pressure, and the EBP reversible syndromes. So a new criterion is amazing and interesting for me to learn. The list of all the published papers show that the mortality of these complications will happen if inappropriate bundle treatment is initiated. So this will complex our medical decisions. This is the case of poor outcome of HIS critical state. The patient is male, 74 years old, diagnosed as chronic subdural hematoma, but he complained about orthostatic headache, back pain headache, and after his complaint about the back pain headache, he go to the massage clinic to do some massage, but it would release his complaints a little bit. So he go to the local clinic to do the CT scan, shows that the crescent subdural hematoma. After the misdiagnosis, he suffered a mistreatment of subdural hematoma drainage, borehole drainage. After that, the midline shift and the brain edema. The patient lost his consciousness. Next one, please. And the midline shift aggregated, and the patient turned to deep coma. And the patient is intubated with mechanical ventilations, and the invasive ICP was under procedures, and the ICP monitoring shows that the intracranial pressure is about 11 to 15 millimeter of mercury. In the observation period, the patient left pupil enlarged. After stepwise ICP control therapy, the patient pupil didn't recover, so they did the deeper compression. Next one, please. And the CT scan. Next one, please. CT scan and MRI scan show that the thalamic infections, the bilateral occipital arteries occlusion, and the infection had been suffered, and the patient maintained long-term vegetated state. After rehabilitation center, the rehabilitation treatment had been didn't do any good to his consciousness recovery. So the patient maintained a vegetated state after 1 year rehabilitation period. And in this period, he suffered a fresh hemorrhage of bilateral posterior lobe. So we retrieved all the background of pathological of this patient. First of all, misdiagnosis of the SIH and the superior tentorial high pressure after the patient borehole drainage, and the patient feel pain after the surgery, and irritation, pain, and agitations cause the patient blood pressure increase very high abruptly after the surgery, and the brain swelling and increase the intracranial pressure. But the CSF leak persistently to release the subtentorial pressure. So the pressure gradient persistently and the gradients increase, so it facilitates the brain saggings. The brain downward movement will cause the bilateral PCA injury, and the congestion of the PCA will cause the embolization of the vessels, and then the infection initiated. All these vicious circles increase the supratentorial pressure, and it all end in a cerebellum tonsillar ectopia. So the patient pathological causes happened, and we didn't end the vicious course in appropriate time. So, in brief, the brain sagging and the pressure gradients cause all these pathological results. So how do we modify our bundle therapy? Next one, please. And we listed another patient, male, 51-year-old, and complained about headache and neck pain with orthostatic for 6 months. After resting on bed for several days, he feel better. And 2 weeks before onset, he go to the clinic to do some neck massage. He cannot suffer the back pain headache, so he go to the local hospital to do the CT scan. And the CT scan shows crescent subdural hematoma and the slit ventricles. And there is high signals around the brainstem. And the local physicians suggest him to follow up, recheck the CT scan and the observation, the procedure of the headache, and have some time to resting on bed. And the first CT scan indicates that there is some pseudo SAH around the middle cerebral arteries, bilateral cerebral arteries. So the patient severe headache based on this severe image indications. Next, please. And we can see the pseudo SAH in the resuscitation patient because of the high pressure of chest when we do the CPR. So the local physicians doubt about some vascular diseases of the brain. So they do the CTA to exclude the vascular disease, and the CTA is negative. Next, please. And the MRI also been done in that time and confirmed the bilateral crescent subdural hematoma, but the clear ambient system and the shape of the fourth ventricle is normal, but the slit ventricle, bilateral ventricle can be seen. And after several days resting, the patient feel a little bit better. So he returned home to another province, his homeland province, to have rest on bed. But after he arrived at his hometown, he redid the CT scan, and the CT scan is like the CT scan before. So after 3 consecutive sneezes, he developed severe headache and lethargy and backward walking gait, unstable gait, and incoherent speech. And then he turned to coma. So the family transported the patient into the local hospitals, and the admission CT scan just like this. We cannot see the ambient system, the obliteration of the ambient system. So he was admitted into the emergency room, and the conservative therapist initiated to treat the patient. After several days, the patient lost his consciousness and intubated. Before the intubation, they redid the MRI. The MRIs indicate that the bilateral patchomeningeal enhancement and slit ventricles and the left side subdural hematoma enlarged. And we can see that coronary image shows that midline shift is very severe, and for about 1.5 millimeters right shift. Next, please. And the bend sign is this. Next, please. And next, please. And the homeland physicians, because of the patient was doubted as a SIH, critical state, so they coincidentally do the fluid image to find the leakage of the CSF, and the image indicate that the C1, the C2 CSF leakage. And the patient lost his consciousness, and the Glasgow coma turned to 5. So the local hospital make medical decisions to do some invasive ones to rescue the patient. And they do the left drainage and ICP, invasive ICP implantations, put to the space of subdural space. So hydrations, hyperosmolarity therapies, and the supine positions to facilitate the ICP control. And then we can see the ICP is about 11 millimeter of mercury, and the heart rate, blood pressure, and the breath rate is normal. They maintain the patient stable. Just like we mentioned before, supplies of ICP management was initiated, such as the supine position. We keep the patient in the lying flat. And the reason is based on the pathological causes of the SIH, individualized pathological cause. So in briefing, we do the basic bundle treatment, normothermia, and hyperosmolarity therapies, and the individualized part of the bundle therapy is lying flat and delay the EBP, because we think that the acute phase of this patient is about ICP control, and the leakage of CSF of the spine will help us to control the ICP. If we lying flat, and the herniation risks of this acute phase will be minimized to the lowest levels. So the pictures indicate that if we keep the patient to supine positions, it will facilitate the herniation. So lying flat maybe optimize our control. Because the critical state of SIH patient, their acute phase, the increase of the ICP were not much higher. According to our series of this 5 patients about the critical state, almost their ICP control is under 20 millimeters of mercury. So we tightly monitor this ICP change. If the ICP is under control, it's okay to lying flat. But if it's increasing abruptly, we will think about the other positions to manage the ICP. Together with the bedside sonography, Doppler sonography, we monitored the blood flow of the Willis circle, and to make sure that the intracranial situation is stable. The ICP is the priority. So because of the name of SIH, it includes hypertension. So it will suggest that the patient will not suffer increased ICP. But in contrary, all these patients, if he go to coma or if he go to the critical state, then the ICP will increase. And so it's kind of a dilemma, kind of a paradox concept about SIH. So ICP control is priority. So after the patient maintained the stable, but the new situation have been observed, brainstem infection. We can see the low density of the brainstem. So the patient's family think about the transportation, ambulance transportation from his homeland to our neurological centers. And after admission in emergency CT, we can distinguish that bilateral subdural hematoma has been better than before, but the signal of brainstem is worse. The ICP is under control. It was about 11 to 15 millimeter of mercury, and the midline shift had been alleviated. So the patient was redid the MRI. MRIs indicate that meningeal enhancement and the ambient system obliterations and the subdural hematoma was drained. And we can see the disformation of brainstem and the perpontine system is compressed, and the midline shift is alleviated after the drainage, bowel drainage. So after drainage and maintain the patient lying flat and transcranial Doppler monitoring and ICP monitoring, and the bundle therapy is initiated, and the patient getting better. And next one, please. After the occlusion of subdural drainage catheter occlusion, we re-put the catheter into the subdural spaces to make the drainage patent. So this every 3 days of the image change that we can differentiate that the brainstem low density brainstem, the ischemic signal had been better than the patient after admission, and the MRI show that the ischemic volume of the brainstem had better than before. The midline shift after 12 days bundle therapies, it's getting better, and the crescent subdural hematoma is decreased. So after the patient reclaimed his consciousness and turned to alert, and we successfully weaned the mechanical ventilation, and we rechecked the MRI. It indicates that the patchomeningeal enhancement, the burn sign persisted, and the brainstem deformation has getting better, and the prepontine system can be discerned, can be visible. But the pituitary hyperemia can be seen in this MRI. And the brainstem infection, we think that it is irreversible, but we compared the patient MRI. The MRI indicate that the signals of the brainstem infection is reversible, and the patient diplopia and vomit problems getting better. And we do recheck the CSF leakage, and the CSF leakage is persistent. So we think about the patient is stable, and the epidural blood patch had been initiated. So this is the leakage location. Next one, please. So 2 months after onset, 1 month after the patient lost consciousness, and we do the local anesthesia, and the C1, C2 epidural blood patch had been done, and the high signal of the blood patch, which had been combined with the agent to show the area, to show the location of the blood patch. After the blood patch, and we suggest the patient to be the supine position and stand and try to walk. And the patient, we can see that he can stand and move his limbs and legs and walk stably. And the CT indicated that crescent bilateral fluid collection is always can be seen. Before discharge, MRI show that the ambient system is visible clearly, but the bilateral crescent hematoma is very thin, but can be seen in following periods. And we can see that the memorial pontine distance can be seen and turned to the normal distance. And the next one, please. And we can see that a pituitary signal turned to normal. We can see the anterior part and the posterior part, and the shape of the brainstem turned to normal. Next one, please. So, as published papers cited about the critical patient, so I think we have the different definition of the critical state. Our critical states include the clinical presentation and image presentation, the loss of consciousness, unstable blood pressure or breeze, dilatation of pupils, epileptic status, and all these clinical presentations indicate that the patient is in critical state. Extra signals, extra image signals beyond the burn score, which was help us to diagnose the SIH patient, even though 20% of the SIH patient present the normal MRI. Pseudo-SIH brainstem ischemia or hemorrhage and midline shift more than 1 centimeters on the fresh brain, PCA infarctions, and the CVSTs always indicate that the patient in a critical state and with a high morbidity rate. Next one, please. Key points of this rescue. We have a briefing. Line flight, sedation, appropriate sedation and analgesics, and invasive ICPs maintaining line flight, except ICP uncontrolled. Osmolarity and 15 to 16 millimeter of mercury perfusion pressure may be appreciated, even though we have no enough evidence to support our opinions. Intubation and tracheostomy will be appreciated, and eucapnia for about 25 to 28 millimeter of mercury will be appreciated. So, as published papers indicated that misdiagnosis of the SIH will always be seen in clinic, especially in the emergency department. So, most of the patient will be delayed treatment and mistreatment. So we must emphasize that the right diagnosis of such orthostatic patient with crescent subdural hematoma, according to its image presentation and its clinical presentations, we must think about more. So, as quoted by the authors I listed here, remain vigilant in broadening our differential diagnosis. That I really appreciated his words. So we must retrieve our right ways to rescue this critical patient. Thank you for listening. If you have interested in share some information or discuss some things with me, I really appreciate it. Thank you. Thank you for your listening.
Thank you very much, Professor E. I think that was a truly great lecture, and you will allow me to say that in my mind we are at the dawn of a new era in neurosurgery. I will come back to that later. First of all, I have 2 comments, maybe 2 questions for you. They're like saying, you know, there's one saying that intracranial hypotension is a benign disease. And thank you very much for showing us your cases. And the second is that it is very, very infrequent. Could you please comment on that?
Spontaneous intracranial pressure syndrome, I think, is a not rare cases, but the complication of critical state is very rare.
Yeah. You are indeed right. And is this a benign disease in your view?
What?
Is this benign in your view? Is it a benign thing or not?
Benign?
Yeah. If it is, how can I say, an easy disease, or you can easily treat it?
I have encountered
patient.
I have encountered such patient, I think about 25 years ago. And this patient was misdiagnosis and mistreatment. And after that, the 33-year-old patient keep vegetated state until now. So it puzzled me a lot for more than 20 years.
Yeah. Well, my opinion, and maybe you can easily understand it, is that this pathology is not benign at all, in the sense that it is not only headache, it is loss of quality of life, and even the risk of serious complications if you don't treat it. Do you agree or not?
I really appreciate your opinion.
Thank you very much. And I would like you to spend some more words on the efficacy of epidural blood patch. What's your experience with that?
We have almost 100 patient epidural blood patch, and most of them is neck or chest spine. For about 10 cases about the C1 and C2 blood patch, I think it's have some high risks about the procedures. So we under the guidance of the CT. So the image will guide us to locate the accurate site.
So you use first of all the MRI to show where the leak is, and then you go for a guided epidural blood patch.
Yes.
ACT guided, something like that. Okay, thank you very much. Ben.
Yes, and this is an interesting question about where should you inject for the epidural blood patch. So I think it's good to have the ultra or even CT guided injection if you can find it. But sometimes in my little experience, then sometimes the leak is there are multiple, and then you have multiple diverticular. And also, we have experience using the epidural blood patch, not at the site, but we do it through the, like from the lumbar, and then we inject until the patients have experience some symptoms of pain, and then we stop to see how patients can tolerate it. Usually it's around around 30 ml of autologous blood. So yes, what do you think the difference between a guided or non-guided epidural blood patch?
We have several patients suffered the multiple leakage of the spine, but I think the blood patch will temporarily release the symptom, and the ceiling of the leakage may be beyond our imaginations. So such kind of patients may need multiple procedures of blood patch after follow-up his orthostatic complaint.
Thank you very much. I also had another question for you regarding the treatment of the subdural hematoma, because I think this is why we are now facing a new era in neurosurgery. Because if you suspect an SIH, I mean, you should be very, very careful in treating that hematoma, because when you end up treating what you see on the CT scan, you end up with a massive failure of your it goes for trials and errors, you know, because you see that hematoma, you treat the patient is not improving, you do the CT scan is with the pneumocephalus, and maybe the midline shift is even worse after the operation, and then you don't know exactly what to do. You finally end up with decompressing the patient. In the past, we were used to say, oh, this is an unfortunate case. How can that be? I do not understand. But now I think we can understand very well. Could you comment on that?
Just like the author mentioned, that we must broaden our view, our diagnosis view, to differentiate the make the right decision, make the right diagnosis.
Yes, yes. Professor E, I have been recently to China. I have been in Nanjing, and I will come back in October in Shanghai. I think there's truly a great potential to combine our efforts with you to try to change our point of view. I think we should work together on this. I think it would be very, very important, because you have a lot to teach to us, you have a lot to demonstrate to us, and I found Nanjing, but I think it's China, in generally speaking, very, very advanced. I was really impressed by you and your technology. I think, I mean, this is challenging. This is a very hot topic, and I think we should combine efforts together.
Thank you. Thank you very much. I really appreciate that. I'd like to enjoy the activities. Thank you.
So, congratulations for these great lectures and this collaboration in advance. And so, are there any further comments from the floor? If not, then I think it will be come to the end of our ACNS webinars. So, we have a really great discussion and today for the two lectures, and thank you so much, Professor Abuzer and also Professor Jin Yi, for these great lectures. And always, I would like to thank you for the support to the ACNS. And on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Abuzer Gungor and also Professor Yin Ji, as well as the chairs, Professor Arthur Guo and also Professor Giorgio Palangi, for the time and the support for the ACNS webinar. A special thanks to Professor Xubin for broadcasting this webinar on the WeChat channel, and special thanks to my co-host Liu Bunxing for joining me today. So with that, I would like to conclude this section. I would like to thank you so much for joining us today, and hope to see you next time.